Hi, welcome back to Cool Ahmed. Today we will be discussing a topic, treatment of dyslipidemia. I made it very simple and this will be going into a playlist called Treat It Simple. This video is specially made for those people who wanted some clinical guidance on where to start with respect to treatment of dyslipidemia, but have not got that much clinical experience. When you have so much of clinical experience, it is what that should guide you towards your medical management. Just a random set of words in some guidelines will not guide you. So I suggest, in case you are very much having an expertise in this treatment plan, you should follow that obviously. But if you are not having one, then this might be a starting video for you that will help you out. So let's go deep into it. So what is not actually covered regarding pregnancy and lactation? Because most of the times lipid lowering therapy is very much contraindicated in pregnancy and lactation. And even in children, we are not covering anything in particular, especially familial hypercholesterolemia. We're not going to cover that. And as well as drugs and doses will not be covered because of possibility of abuse, as well as even excessive relying on this content for real-time practice, which I do not recommend. Then even in very high risk cases of atherosclerotic cardiovascular disease, it's not going to be covered because it could complicate this PPT. Now, this is a very good PPT for MBBS as well as MD, but for DM cardiologists, this may not be a good PPT because of its oversimplification. Still, the cardiologists, they can just look into this PPT, correct our viewers in their comments in the comment section so that they practice better. Doctor, am I supposed to get a fasting lipid profile now, or should I get it some later age? Your answer should be that as long as your patient is 19-year-old or more, get his fasting lipid profile done. If his lipid profile is not available previously, then advise him to get it done every 5 years as a part of screening in case the lipid profile turns out to be normal. If it is abnormal, then choose your own frequency. Second question that is going to be what lab I should send him to. You choose a lab that is going to have a advanced equation calculations. Like when you see a lipid profile, to one side there is going to be a method. In the method section, there will be some values of the lipid profile that will be saying as calculated. And this calculated equation that lab should be using would be a better equation compared to the previous equation. So currently the better equations are Martin, Hopkins, Sampson and NIH. So these are the better equations. Then the lab report should also contain non-HDL cholesterol. That is really important because over the time, as you are going to check for the target levels, you are going to look at non-HDL and LDL. Should I get any other test done? Yes, because lipoprotein A should be done at least once in the lifetime in order to estimate the risk of atherosclerotic cardiovascular disease. So if it is 250, it's going to be two times more. And if it is 430, it's going to be four times more. You explain him the risk of not getting treated for dyslipidemia. That would increase its compliance to the drugs or for that matter lifestyle measures. So your patient, if you are very much sure that he is in a spectrum of overweight or obese, certainly suggest him to lose weight because even 5% reduction of weight matters. So once the 5% reduction is achieved, you can motivate him to reduce much weight. Do not set a unrealistic goal that will only demotivate you. Counsel him in a way that 5 kg weight loss is sufficient. Then comes exercise. I would say it as most difficult part of the life. So I suggest this not only as a treatment for discipline, it is also for prevention, not just exercise, but also the weight reduction as well as dietary factors. They play a role in keeping as well as preventing dyslipidemia. So for any person, as long as they are capable of exercising without so much of discomfort, we counsel them to exercise. So let us say I usually go with 3 days of strength training with little cardio and 4 days of cardio alone. Tell him to start small, and as he progresses, he can increase the exercise to his comfortable level. Regular exercise is matters most. One question a patient never misses is what he should have. And then what he shouldn't have. So there are three things he shouldn't have. One is alcohol. Second is added sugar. Third is fat. So here comes the content. What made you click this video actually? The way we are going to approach. So first thing is whenever you see a lipid profile. So with lipid profile as well as some other values, demographic data, blood pressure, medication history. Based on that, we are going to calculate prevent ASCVD score. This score you can Google it and then calculate. And once you get this score is nothing but 10-year estimate as well as 30-year estimate of risk of atherosclerotic cardiovascular disease. So once we are ready with the score, we look at the 10-year risk. If it is less than 3%, then it is a low risk. In a low risk case, we do not treat unless there are two specific conditions. That is, one, LDL cholesterol greater than 160. Second condition, 30-year risk score is 10% or more. If any of the two is present, then you are going to treat the case. Maybe same thing works even for second scenario, that is 3% to less than 5% case. That would be called as borderline. And in borderline cases, it's more like a maybe scenario. That is, you treat, otherwise you do not treat, but the decision is usually made by investigating further. So we will look into that later. Third thing is intermediate category. In this category, the person is going to have 5% to less than 10%. These people, what we do is we treat the case with lipid lowering therapy. Similarly, for high risk, it is greater than or equal to 10%. Even for them, we are going to treat. Borderline cases, like I said earlier, treatment is like a maybe case. So in this maybe case scenario, we are going to do coronary artery calcium score. So coronary artery calcium score, once it is done, we see whether the score is 0 or more than 0. If it is 0, do not treat. May do another coronary calcium score maybe after 5 years, then decide whether you want to treat the case or no. But if it is greater than 0, then treat with a lipid lowering drug. So do we have to calculate all times this score? Actually, yes, because you want to stratify them into whether they are falling under high risk or not. Because usually in high risk, we are going to intensify the therapy. Initiating treatment, maybe it's not always the score need to be calculated because any diabetic patient who is greater than 40-year-old should receive a statin. Similarly, chronic kidney disease stage 3 should receive a statin. As well as familial hypercholesterolemia cases, they have to receive statin therapy. So usually statins are the ones that we prescribe initially for lipid lowering therapy. And the next thing is when to check the lipid profile. So first let us check it in 8 weeks, that is after 2 months, and then see how the treatment has progressed. Based on that, you can decide maybe less frequently or more frequently depending on the lipid profile. I think now you can understand why I am suggesting non-HDL cholesterol to be there in the lab report because it is one of the targets you want to look for. So we usually look for LDL as well as non-HDL cholesterol targets. The ultimate aim is to achieve the targets in the specific population, usually for those people with low risk or borderline risk or intermediate risk with a CAC score of 1 to 99. We keep a target of less than 100 for LDL and less than 130 for non-HDL. Now, I will tell you an easy way to remember the other two targets. The only thing you need to do is subtract 30 from 100 and then subtract 15 from the subtracted 30. Like, for example, let us say LDL is less than 100 in the first scenario. And in second scenario, it's going to be 100 minus 30, that is less than 70. And in the third scenario, it's going to be 70 minus 15, that's going to be 55. Similarly, for non-HDL, it is same. 130 minus 30, 100. 100 minus 15, that is 85. So this is how you can remember. What are the other two categories I was talking about? Less than 70 and less than 100. That would be High risk of atherosclerotic cardiovascular disease when you do the prevent ASCVD score. Second thing is clinical atherosclerotic cardiovascular disease patient. And next is CAC score of 100 to 990. And in those whom there is high risk clinical ASCVD, CAC score of 1000 or plus, CKD stage 3, you are going to put them on very much stricter target, less than 55 and less than 85 respectively for LDL as well as non-HDL. Thank you very much. And subscribe as well as like this video and share it to those people who will be needing it. Comment on your experience with dyslipidemia.